In this chapter, we will be looking at the elbow, forearm, wrist, and hand. Understanding the structures of the elbow. It is a hinge joint involving 3 bones that have multiple bony structures that can be palpated. A major observation of the elbow is the carrying angle. The carrying angle is measured by a manual goniometer with 2 drawing axes of the arm and forearm. The axis of the arm is defined by the lateral border of the cranial surface of the acromion to the midpoint of the lateral medial epicondyles of the humerus. The normal carrying angle is anywhere between 5 and 15 degrees. This can be used to determine if an individual has cubitus valgus or varus. Cubitus recurvatum should also be evaluated, meaning the ability to hyperextend your elbow. Acute injury is commonly due to a Fuchs mechanism or direct blow. Protective gear is often worn to reduce the severity of injury. This is seen in volleyball, basketball, lacrosse, football, hockey, etc. Chronic injury is seen in repetitive movements seen in tennis, baseball, golf, etc. The olecranon bursa is very superficial, which makes it susceptible to acute or chronic olecranon bursitis due to a direct blow or multiple blows. Spontaneous swelling is visual with the area normally being warm to touch. Ice and rest is acute care. However, if swelling is not resolved, then the area will need to be aspirated. The picture on the right allows you to appreciate how superficial the olecranon bursa is to the skin. The picture on the left is an example of an acute olecranon bursitis case. These can honestly get bigger than that. It is important to understand that while some loss of range of motion is acceptable, any extreme loss of range of motion or strength should be referred to imaging to rule out a fracture. Lateral epicondylitis is very common, obviously in tennis players, but also in field sports such as javelin and discus throwers. To assess for lateral epicondylitis, you palpate the lateral epicondyle, which you could notice that it is swollen, but it doesn't have to be, and then have them resist wrist extension against you. You can also have them attempt to pronate against resistance, but sometimes they can have their normal strength in pronation and still have epicondylitis. Golfer's elbow can also be seen in baseball and softball, as well as in field events such as hammer throwers. The same evaluation process as tennis elbow applies, except you are palpating the medial epicondyle. Rest is the key in treating both tennis and golfer's elbow. NSAIDs are recommended to help decrease the swelling and pain, with rest for about 1 to 2 weeks. This is common to help decrease the irritation. If an individual does not take the proper resting time, this injury can persist and reoccur, and worsen, with severe cases needing surgical intervention. A dislocated elbow is common in contact sports and occurs most commonly by a Fuchs mechanism. The elbow dislocates posteriorly most of the time, but can dislocate laterally or anteriorly. This injury requires splinting and referral for imaging and relocation. Elbow dislocations are normally relocated under anesthesia, and athletic trainers typically never relocate on the field due to the vascular structures potentially being compromised. The video shows Andy Jonovich dislocating his elbow as he is brought down to the ground. Proceed with caution while watching this video if you are squirmy. Elbow fractures normally occur with a fall into a flexed elbow or direct blow. Fuchs mechanisms often fractures the humerus above the condyles. There can be a deformity, but you are mostly looking for severe sharp pain with palpation and loss of function. If there is a bone that chips off, you can have a floating body, as they call it, which can prevent full extension and flexion as well. You always want to assess circulation, splint, and refer to a physician in the event of a fracture to the elbow. Ulnar and radial fractures are common, especially in children. There are a few different types of radial ulnar fractures discussed in the next slide. It is common to feel a pop followed by pain, swelling, and potential deformity. Forearm is splinted and referred. If displaced, it can require surgical interventions. However, most cases only require casting for a few weeks. A Colles fracture is a distal radial ulnar fracture that occurs when you fall onto an extended wrist. This is also referred to as a silver fork deformity, as the deformity causes the wrist to look like a fork. The opposite of a Colles fracture is a Smith's fracture, which occurs when you fall on a flexed wrist. Both of these normally have a deformity, but sometimes this isn't as obvious. Therefore, there can be damage to the tendons and median nerve. Both of these fractures need to be splinted and referred to a physician for X-ray and immobilization. This image shows the directions that the bone are displaced for each fracture. Carpal tunnel syndrome is a chronic painful injury that is commonly caused by excessive typing, writing, etc. We can see these injuries in sports, most commonly in cyclists, gymnasts, and esports athletes. There will be mostly paresthesia, especially in the middle of the palm and up through digits 2 through 4. Rest and NSAIDs are the normal treatment. However, it is common to need a corticosteroid injection or surgery if the injury persists. These more serious interventions are not super common in athletics. The video shows a real carpal tunnel release surgery. Proceed with caution while watching this video. Scaphoid fractures occur due to a Fuchs mechanism where the scaphoid is compressed between the radius and the carpal bones. Pain can be palpated in the anatomical snuff box. This injury should be splinted, however, it can often be missed in initial evaluation. Immobilization is required with the diagnosed fracture and then strengthening needs to occur. Prolonged protection is critical in the months following the injury as well. This fracture has a terrible healing rate due to the poor blood supply to the area. Surgery is common due to this lack of healing. Hamate fractures. Hamate fractures is referring to the hook of the hamate that can be palpated. When an athlete is holding a bat or a tennis racket, etc., and they fall while holding that object, the hamate can be compressed against that object and fracture. The ulnar nerve runs closely to this bony structure and therefore is commonly compromised, resulting in wrist pain, weakness, numbness, and tenderness. Casting the wrist and thumb is the normal treatment for this injury. Ganglion cysts are very common, especially following injury and in people who have osteoarthritis. The cyst is jelly-like when palpated, and aspiration is the common treatment for these cysts. This video shows a live surgery for ganglion cyst removal. Proceed with caution. Boxer's fractures is a fracture to the fifth metacarpal. This is caused by a direct axial force. This is common in fighting when the individual punches leading with their pinky, which is poor technique. There is normal palpable point tenderness in the bone, and if a fist is made, then the knuckle will be depressed. Any deformity must be reduced and splinted by a physician. Mallet finger occurs with a blow to the tip of the finger, avulsing the extensor tendon from its insertion point. Obvious signs of the distal phalanx presenting in deflection with the inability to extend the bone. Finger is splinted into a neutral position for 6 to 8 weeks. This is commonly seen in baseball, softball, lacrosse, and any sport with an object that can strike a finger and force it into hyperflexion. Boutonniere deformity is a rupture of the extensor tendon in the middle phalanx, forcing the distal interphalangeal joint into extension and the proximal interphalangeal joint into flexion. There is an obvious deformity and loss of range of motion. Splinting is required for 5 to 8 weeks, with manual flexion performed to the distal phalanx daily. Jersey finger presents with the finger unable to be flexed at the distal interphalangeal joint. This occurs with the flexor digitorum profundus tendon being ruptured, which occurs when an athlete attempts to grab onto another jersey and is forcibly pulled from the hand. The finger remains extended, and the athlete will have point tenderness over the distal phalanx. This injury requires surgery and a 3-month return to play process to help decrease the risk of re-rupture. Gamekeeper's thumb is a sprain of the UCL of the metacarpal phalangeal joint of the thumb due to forceful abduction and hyperextension. Athletes will have trouble pinching and will have tenderness over the UCL on the medial aspect of the thumb. If there is instability, then surgery is recommended. If the joint is stable, then the thumb is splinted. This is a common injury in soccer goalies and can also be seen in volleyball attackers. Finger dislocations are pretty obvious with a deformity. It occurs due to a blow to the tip of the finger and can be a closed or open dislocation. Reductions of dislocation fingers are common for athletic trainers. Dislocated fingers are normally relocated with traction to that finger. Fractured fingers can occur due to many different mechanisms. Often can be seen with a deformity, but not always required. Splinting is required in a slightly flexed position to relax the flexor tendons.